Not very helpful. Okay. I don't see anyone asking. We could ask the question one more time. I was on mute. So do you want to ask one question more time?
Yes. Is there anyone on the line who would like to bring a comment who maybe has not raised their hand yet?
I would like to make a comment. My name is Jewel Wickman.
Okay, thank you. Your address, please.
17577 Ridge Avenue, Spring Lake, Michigan, 49456.
Thank you. And you may go ahead.
Oh, okay, thank you. I would like to make a request to the board that the CMH finance meetings get unbundled or separated from the CMH board meetings. Within the last 2 years, Lynn Doyle made a request to Matt Fensky to have the CMH meetings absorb the finance meetings. And I think that that really takes away from what we need to hear about during the CMH meetings, which is the committees, the progress of the committees that the CMHs have, the progress of the programs and all the initiatives that they have for the people. So I would like to request that we go back to the old way and we separate out those two meetings and they're no longer bundled into one meeting. I would also like to request that we make more focus on the people and have more transparency. Right now, the way the CMH meetings are set up, it's set up for what's going on at the state level, what's going on at the LRE level. And there is very little talking about what's going on at the local level. What is our local CMH doing to serve the people? So I would like to request that we make a move more towards the people again. And then I would also like to request, lost my train of thought. I would also like to request that the self-determination committee that's been going on for the last 6 months be made public. Let's see the meeting notes. Let's have more transparency. The board has no idea about the self-determination committee that's been taking place over the last 6 months. And they've been talking policy and procedures and budgets, and this has not been disclosed openly to the board. So how can they provide oversight to something that they have no idea is taking place?
All right.
So those are my main concerns.
All right.
Oh, and I would also, oh, sorry, one more thing. I would also like to understand, have more clarity on what transfers is. In the CMH activity sheet that's presented to the board every meeting, there's a line item for transfers. I would like to have more clarity on what that transfers line item is. And also when it says Medicaid budget for $40 million, what exactly makes up that Medicaid budget? What waivers and which populations are they serving for that 40 million?
Okay, very good.
Thank you.
Thank you for your input. All right, then moving on. By consent, I would like a motion to approve both the agenda and the minutes that were sent out to you. Let's get a motion on the table. It's been moved and supported. Is there any discussion on either the agenda for today, January 23, or the minutes from our December 19 meeting? Hearing none. All in favor of approval, please indicate by saying aye. Aye. And those opposed, same sign, please. Thank you. That motion carries. And next on the agenda is a presentation. Rich, thank you so much for stepping up. For us. Yeah, same for you.
All right, I'm going to be talking about the NIMBUS indicators, which is our timeliness indicators. I did give myself a explanation for each one. So you guys, one of these, it explains the rationale for each of the indicators. She has those. I know it didn't go out in the packet, but I
Okay.
wanted to make sure that everybody understood what indicators
So
were.
I'm gonna send them around and they're 2 pages and they're not stapled together.
Okay.
It's giving me- it's giving me
Sorry,
why,
Okay.
so.
Way to go, Rich.
I missed that. But anyway, the dashboard is on attachment eight, and it looks like this. We're gonna go into the fourth quarter, which is July to September, the very far right-hand side. And starting out with indicator one, which is the pre-admission screening disposition, 3 hours or less for children and adults. That's indicator 1A and 1B. We did fairly well in that indicator. There is a standard and a target for this indicator, which is 95%. We got 100% for the children and 99% for the adults. The next two indicators, indicator 2A and indicator 3, don't have current standards set right now. And DHHS is still working on them, and there's a work group formed. So we'll find out soon what that would mean for us, if it's going to be at a 50%, 75%, we don't know. So that's coming. But anyway, we have been set up for this to collect the data for some time. We've been doing it for a year or so. And the scores are there. So for indicator 2A, for MI child, we have 59.8. We have 54.8 for MI adult. DD child took a dip, and we're looking into the data as well right now to see what could have caused that. I do have, it is a very small N, it's 12 people. So I'm actually diving into each of the circumstances of why. I did find out that 3 or 4 of them were no-shows already. And then the other 3 were the guardians requesting time outside of the 14 days. And so, indicator 2. That's 14 days. Well, right now there's no target for those, so I'm gonna skip over to indicator 4A, and then 4B and number 10. Sure.
I have inquiry.
Sure.
It seems like there's a lot of variation in the numbers, and are these new indicators? Is that why you don't have a target currently?
Yeah, so these have been revised, 2A and number 3. They're new, they've been around for some time. But then there was a study done that they used to be 95%, but there used to be a lot of exceptions to the rule. Now what the state is saying is no more exceptions. Everything gets counted against, if, against the benchmark, if it's not.
Hello?
Yeah, they're getting more directed in terms of, what is the cause, and if we could do something about that. So, yeah, 8.3. So that's the low end. There's
Yes.
12 of them.
I got it.
What time is the earliest?
Who's that, Julie?
That's the,
I feel like I'm talking on top of someone, but I think that's a side
Yeah, yeah, it's a side
conversation.
conversation, correct.
Okay. The targets are set by the state.
The state for all of
And
these.
they just haven't gotten to, because of the
The
changes.
changes, yeah.
Yeah.
So they redid the study and said, 95 is no longer going to be that they're still reviewing what the new standards are going to be.
Thank you.
So, yeah, new targets, new benchmarks for those.
That's their most.
It's still the same requirements. It's still going to be psychosocial within 14 days, but in terms of what they allow as excusable, like,
If some, if somebody came in and asked to see a female minority as a worker, that name would be taken out, so it wouldn't be counted against you, because it might take against us, because it might take us a little bit of time to find a staff member like that. So there was lots of exceptions, but they were driven by the consumer at, their request for something.
so one good example of that is if a consumer requests an appointment outside of the 14 days, which already puts us out of the date that it's required to be done, there's nothing we can do about it. Or there's a no-show, we are now supposed to count those towards our
These were
numerator
allowable.
before, and now they're not.
Right.
Which puts us really, it's gonna be hard to meet it when they come out with a benchmark.
Do we have any input from the state as to when they will
So they're saying
give those
about,
benchmarks?
yeah, it's about March or April, the work group is forming again, but it's already, I already formulates that the no-show and some of the other exceptions that used to be in place are gonna be challenged. So right now, state is saying, no, We don't have anything yet, so.
So we don't have a definite date.
not yet.
Hmm.
Rich, clarifying question.
Sure.
For these 4 quarters that are represented, is the assumption in each of those that there have not been exceptions removed in each of those quarters, or when did that begin?
So for 2A and 3 for this year and last year, there was no benchmarks. But for indicator 1, 4, 4A and 4B and 10, the old benchmarks apply. So that's where you'll see the target.
Right,
It's set right on there. Yeah.
but in all 4 of these quarters, are you including people who no-showed? Those exceptions that you talked about that
Yes, so-
previously were allowed to be removed
So
from,
those are getting removed from the
calculation.
totals. And
they currently are?
Yeah.
Okay, and in, so those numbers are all consistent?
again, for indicators 1, 4, and 10. For 2 and 3, we just include everything in the denominator. That's why the numbers are much lower. Okay. So 4A, which is percent seen within 7 days of an inpatient discharge. For children, we have 100% for the fourth quarter or July to September. And then for the adults, we have 89.7. So in terms of that not meeting the metric there, the reason was we had 4 outliers. So we actually had 11 exceptions. There was 49 adults that were discharged. 34 received the follow-up within 7 days. So that puts us as 34 out of 38, putting us at 89.5. So we have to subtract the exceptions from that list because it's still one of those metrics that exceptions are allowed. 4B is for percent seen within 7 days of detox. We did fairly well, 96. The benchmark is 95. And then for indicator 10, this is where we have a little bit of we want a 15% or less in terms of the benchmark. It's inpatient recidivism. And again, you'll see in the sheet that I provided what that indicator is about. We don't want the number to go over 15%. So for the children, we had 16.7. We actually had 7 discharges, 1 exception. We had 1 case of recidivism. So that's 1 of 6 that's where we get the percentage, 16.7. And then for the adults, we had the 49 discharges. We had 1 case of recidivism. So 1 of 49 is 2%, which puts us well below the 15%. All right. If you guys have any questions or anything on this, on the metric itself, for the shoot me an email or not.
One question,
Sure.
any particular causes for the red lines that we have where we did not meet?
You know, in the past, so when I presented the data in the past, what we've actually done is actually factored them on a quarterly basis. So we have one person, one of my staff, working with the teams and the providers as well, because this also includes our provider network. So we reach out to them. But I can look back on those other ones. I know we handled it quarterly now. So if we're out of compliance in terms of one of the metrics, we go through a process.
can't
where
fix
we
it.
reach out. And they all vary in terms of reason. I mean, you know, it could be a small end. There's 3 or 4 people, like one person is out of compliance. Yeah, so we handle it in the, you know.
So the no-show rate, well,
Yeah.
because we, interventions to prevent no-show.
Exactly.
Is that something that, I mean, is that a consistent issue for you, or is this kind of?
It actually has been more lately. We actually have looked and worked at the state level on some quality improvement projects on it. We did a project not long ago and we worked with NIATEC, which is a quality improvement, and several members of the state, several CMHSPs that all participated. And we improved, but then again, you know, drift over time. So we're constantly having to address what is going to work for this group, for this population, what it's not. We're looking at, go ahead.
Do you have video visits? So.
Yeah, we do. We have telehealth. We One of the things we were looking at was transportation, is getting to appointments, appointment reminders, is only something that we can increase the frequency of. There's things that we've tried that we continue to try.
The telehealth options actually really helped us to lower that no-show rate, especially with prescriber visits. So we, as long as we're able to, we've mixed up appointments between in-person and telehealth. It's up to the person whether they want to be in person or not, but that seems to have made a pretty big difference in our no-show rates, is being allowed to have that option.
Yeah, and again, I don't usually put all the details because usually has a PHI in it. So, but if you're interested in knowing more detail, the numbers and the calculations, let me know. We're happy to sit down.
Thank you very much.
Yep.
And then we'll move on to item 7. Is there any old business? To new business. And first we will look at our.
Good, hello.
CMH. We're going to go through the financial statement of activities through the end of December, so the first quarter of this fiscal year. You'll find that in attachment B. This is a format that we present monthly. I'll just kind of walk you through, since there are some new faces here, how this information is structured, and feel free to interject with questions. We'll start in the upper left corner. That is our mental health fund. So mental health, the bulk of our services, that's our Medicaid capitated. We have information about revenues and expenses. It's kind of structured with revenues and expenses. The revenues are sorted out a little bit by some of the funding sources within Medicaid for Healthy Michigan program, general fund contributions from the state. First line, obviously, is annual budget, year-to-date budget through the end of December, year-to-date actuals. So I'm giving us an over/under number. For the mental health fund, you'll see that revenues exceed expenses, so we're tracking pretty well. Our expenses for the first quarter, a lot of time and effort is spent in October and November, kind of wrapping up our previous fiscal year. So some of our numbers, that gap is a little wider maybe than normal when we're running on regular transactions, trying to catch up with cleanup for the previous fiscal year. We're just starting to hit our stride for getting back into the billing schedule for current year payables. But you'll see that we have received $12.5 million in revenue and have expenses at just under $9 million to date. For mental health, moving to the right, we have our SUD, or substance use disorder fund. Yeah, I guess, and another thing I'll point out, one of the person that put this statement of activities report together kind of color coded it. So when there are things that maybe stand out as unusual, or if there are real issues with the budget, they kind of color code it. Green is good, ready to go. Yellow, we have as cautionary. Red is warning. You'll see in the SUD fund, within our revenues from grants, I did highlight grants revenues as cautionary only because we are waiting on signatures for some grants so that we can receive the allocation. It's not a real big concern, but it is something that shows, if you look at the year-to-date budget to actual, it shows a deficit. So I wanted to highlight that is something we're waiting on some contract signatures to for revenues that are pending with grants that we were awarded. Expenses, again, are kind of just starting to pick up for the year. We had a 3% increase for SUD expenses in January 1. So anticipate that, you know, revenues and expenses will balance out and continue forward and remain on budget for the SUD fund. Going down to the bottom left corner, the millage fund and grants. This one here, I think the caller online made a comment about the transfers. I can explain. Revenues for millage include not just property taxes or millage dollars, but we also use that fund for grants that have in-kind match, or that for keeping them separate from Medicaid services because they're grant funded. So it is, this fund actually is a collaboration, or it's a joint resources for both revenues and expenses, both for grants and millage community-based projects. Revenues are tracking well. We have a surplus over $1 million in the year-to-date actual. When you look at expenses, what happened in the transfer line of the expenses is what a transfer is in the general ledger is when money is transferred from one fund to another, and it shows as a debit into the expense line because it came out of a revenue, but we're not charging an expense, we're charging a credit into the expenses. And that transfer line of $1 million is related to the ARPA project that CMH was awarded for prescriber recruitment project. I don't know if you've heard about that, but so it actually creates even more of a increase in our net position. So everything within the millage fund is doing well and healthy and on track. It does kind of read a little funny on the page, but hopefully that makes sense. And then the bottom right corner is a little quick look at our total Medicaid funding. So one of the things, you know, we receive payments from Medicaid payments on a monthly basis, and this is a quick measure of what's been received in funding versus what we actually budgeted to date. So when it gets skewed where our budget exceeds our actuals, you know, is when it's problematic. But even now, our budget, we have a surplus in budget as well as a surplus in actuals received. So we're in a very good, healthy position right now.
Is actual, does that include any receivables or just actual receipts?
Just actual receipts.
Got it. Okay.
Right, are there any other questions for Amy? Thank you for the written. Financial report for December as presented.
Support.
It's been moved and supported. Is there any further discussion on the financial report? All in favor, please indicate by saying aye.
Aye.
Opposed, same sign. Carries. And next, a new business is the attachment C, which is Eston's application for the Lakeshore Regional Entity Board. And I know we received this well in advance to be able to read through it. And I'm wondering if there would be someone who would make a motion so we could put this on the table for further discussion.
So moved. Or
Okay, it's been moved and supported. Any discussion on the appointment of Stephen on the LRE board to fill an unexpired term beginning January through September of 2025? Hearing no. All in favor, please indicate by saying aye. And opposed, same sign, please. Thank you. Item number 9 on our agenda is Lynn, our Executive Director's report.
Thank you. For those of you who've been here for a while, you might have noticed we did not present contracts. In a holding pattern because we obviously have a new county commissioners and a new county administrator. And we just spent last week some time with them, teaching them how to use our contract system and our signature process. So I anticipate that we'll get the contracts that are pending at our next board meeting. So just if you're wondering where that part of our agenda went, that's we do actually have quite a few pending contracts. So I will get us started. From the state, again, I've said this before, but truly, when we get together as CMHs in meetings, the biggest issue continues to be staffing concerns, and that is all the way from professional services down to direct care workers. Some positions are harder to fill than others. We're doing okay here at CMH with positions being filled internally, but truly continue to have issues with our provider network being able to fill some of those community living support workers and direct care workers, for instance, in our group homes and some of our employment programs. One of the things that's going on at the board association, so the Community Mental Health Association of Michigan, is working on an advocacy strategy, looking at really trying to bring that minimum hourly wage up to $18 an hour. They've done some research with CMHs that have been offering that wage level, and it looks like there is more people interested in those positions if we can get it up to about that range. Locally, we aren't quite at $18 an hour. It ranges starting from probably 15 all the way up to 17. I think $18 an hour would really be able to be competitive with some of the other entry-level positions in the community. So I'll keep you informed on that particular project at the board association. Other things at the state level, in recent months, I've let you know that we were awarded a block grant from Michigan Department of Health and Human Services to help stand up a children's mobile crisis service. For those of you who have been here for a while, you know that we've attempted on 2 occasions to get that program up and running with not really good results. What happened in both cases was that the 2 staff that are mandated in the program ended up leaving and finding new jobs because we just couldn't keep them busy enough with the call-ins. So this particular grant, in order to receive the grant, you had to agree to participate in a learning community, which the first meeting was last week. And I thought it went well. Really, the learning community is to help the CMHs who are also struggling to implement a children's mobile crisis service team or program, really learn from each other and learn best practice for how other states and communities have implemented their program. So I think that's a good thing. The state definitely heard the CMHs when we let them know that it was going to be able to stand up these teams given the staffing crisis that we're all currently in. One of the things that I participate in quarterly is a directors forum, which is a meeting with all CMHs and PIHPs, that's prepaid inpatient health plans, with the board association. And part of the agenda includes inviting officials from MDHHS to talk about some of the issues that we have concerns about. So some of the things on the agenda for this week are efforts that are being created to address the behavioral health workforce shortage, efforts that are being made to reduce administrative burden in the system. We are very, very heavily mandated to produce data and reports. Sometimes my staff feel like most of their job is doing paperwork and not as much doing what we're really here for, and that's serving people. So I think both of those projects, I'll give you an update on after I hear on Thursday what progress they're making on addressing those issues. From the Lakeshore Regional Entity, I don't have much to report to you. I've kept you up to date, hopefully, on the deck action. And that's a declaratory judgment. And that has everything to do with the past liabilities that some of the CMHs are owed money from past years of using their own dollars when our Medicaid revenues were not adequate to cover the need. So that meeting was actually supposed to be today, so I don't have any news for you on that, but I'm imagining I will hear pretty soon. Just so you know, for those of you who are new, Ottawa County CMH is not part of that historic deficit. We are currently cost settled with the region, so it includes some of our partners, not us. From CMH, we have a lot going on as well. Welcome to our new board members. If I happen to use initials that you don't understand, please let me know. We have literally, I think, hundreds of them. Or anything else. We do have a fairly complicated system, and I am happy to slow down and answer questions.
A while back, we talked about putting a list of acronyms together.
Yeah.
Maybe that could be provided to.
Yep.
Yeah, yes, and I
They are-
emailed that out to everybody too, I believe, so.
So the new board member handbook, it's great. It's right in here, and we will get you your very own copy of those.
Yeah.
I sent
believe I
I
have a
sent it
copy.
out like,
Yeah.
yeah, I sent it out like
Okay.
right after you asked for it.
Well, I mean, if it was accurate 2 months ago, that doesn't mean
Yeah,
it is
right.
this
Right.
right now.
I try to keep it updated.
Because the acronyms just keep changing and keep growing, it seems. I'm sure all of you know, we've had some pretty significant changes with the Board of Commissioners and the county administrator. I have met with the new administrator, and Patrick Waterman is the fairly new deputy director. They came down and I spent some time going over CMH and what we do, why we do it. I've also met briefly with our new commissioners to give them a super quick orientation. But I will continue my efforts to provide as much as I can as far as information and education about what CMH does to all of the new commissioners. We are going to be scheduling program and department updates for this board over the next 6 months. Hopefully, it won't even take that long, but a lot of you who have been here for a while, I think I'm probably more familiar with some of the programs and the work that we do here, but I know with all of the new folks, I'm sure you would like to hear from the programs themselves and the teams themselves, what they actually do. So we're going to start having, as part of this meeting, presentations from my staff to give you an overview of what the actual teams are doing, what some of the grants are up to as far as implementation. So anything that you're particularly interested in hearing first, please let me know, and we'll get them on the agenda sooner rather than later. So just some points of clarification as well, obviously with the new board members and commissioners, we lost some of our officers on this committee. So Bonnie has very graciously agreed, she was vice chair, so she's agreed to step into the chairperson role. That was Matt Fensky as the chair, and then Doug Zalstra was our secretary, and he's was not assigned to this committee. So our next board election meeting happens in April. So Bonnie has agreed to cover all bases for the next 3 meetings. And I think we'll be okay with that. Our bylaws state very clearly that in the absence of the chair, the vice chair can take over. There is nothing in our bylaws that talk about secretary, but really the secretary has had not a whole lot of responsibilities. One of them is signing off on minutes. So I think we'll be okay for the next couple of months. If it looks like there's some issues with that, we can always talk about what we want to do next with elections. So yeah. I did want to let you know that in the last 2 months, we have been in close contact with one of our contractual programs, the Holland Drop-In Center. The Holland Drop-In Center is it's a contracted organization that is peer run, and it's intended to, Stephen, you go there?
Yeah.
Yep. So it's intended to provide social interactions. They have groups that they conduct. They go on outings. They have special projects. They cook meals together. So it is one of 40 or so peer-run support programs in Michigan. And the reason we've been in closer contact with them lately is the director there let us know that in reviewing some of their past finances and tax obligations, that they had some concerns of past taxes being due, business taxes, and also they realized that their nonprofit status, the documentation that needs to be reported to the state on that had not been done. So they have been meeting with, they now have an accountant that they're meeting with, and they've also been working with an organization called JIMHO. JIMHO stands for Justice and Mental Health Organizations, and they are a drop-in center in Lansing who part of their responsibility is to help other drop-in centers. They provide training on how to run a drop-in center, and so they've been working with the accountant and JIMHO to kind of go back and look at their records and see what's missing. They also have been in contact with Holland Police Department to help them rule out whether there will be any criminal charges. At this point, there's only an investigation going on. So I will keep you updated on that. I have spoken to both our corporate counsel and the previous county administrator, and I also let John Gibbs know about this in an email recently, and I'll try to get some time to talk to him about it. Just so you know, and I think we're going to get everything squared away there, but I'm grateful to them that they're looking into some of these issues in the past.
In existence, this is the first year.
Oh boy, at least
Yeah.
89.
99.
Oh,
It's been a
99.
long
Thank
time.
you.
Yeah.
Well,
It's had a couple of
They
transitions.
moved a few times.
Yeah.
Did they have a leadership transition?
Yes, they did. Yep. We have had 2 roundtable discussions so far. We have another one scheduled on February 14th in Hudsonville. Those are intended to be places where I can share some things that are going on at CMH, but also listen to concerns and ideas. We've got good attendance so far, which is a great thing. We have had roundtable discussions in the past, and not a whole lot of people showed up. So I'm happy that we've got some people who have things on their mind and they're willing to share those things. We're keeping minutes, and when we're done with the meetings, my plan is to review some of the things that bubbled to the top and put some work plans around how we can address some of those concerns and issues. We will be asking the county commissioners at the next finance meeting for several new positions. We really, at this point, I feel like many of our positions, mostly case management and supports coordinators, are true that they're maxed out. Many of our case managers have in excess of 50 people on their caseloads, which is about 50 more than they probably should have. So we will be going to finance and the county commissioners to ask for 6 mental health specialist positions. That's the case managers, the coordinators, a community health worker, and their job is to help us coordinate physical health care issues with mental health concerns, and SUD, substance use disorder program supervisor. If you'll recall, many years ago, the separate substance use disorder system called coordinating agencies got merged into the CMH system. And when that happened, at the time we were at a place financially where we could not hire new staff. So we really asked our current staff to absorb those additional responsibilities. And we've kind of stuck with that same system for too many years. At this point, I think a separate program supervisor fully dedicated to substance use disorder services could really help that program grow and give the multiple contracts that we supervise and the services that we provide. I think that a dedicated program supervisor could go a long way in growing that particular area and department in our service delivery. We don't use labor statistics, but if you have anything you'd like me to look at, I would be happy to look at that. What we typically do is we compare ourselves to our regional and statewide partners who are doing CMH work and try to get a feel for what their caseload sizes are, so that we know we're in the ballpark. Yeah.
Like entities.
Yeah, and we definitely do that. When we've researched those statistics, our numbers are pretty high. I would think if you ask my staff here, they would tell you they're struggling to keep it up, do all the work that we've asked them to do. So, all right, I'm gonna leave you with some general announcements. We found out that our annual site review visit from the region is going to be taking place March 7th to the 10th. It's everybody's favorite time. We have people who enjoy our audits, so I appreciate those folks very much as well. Our CARF accreditation, I've let you know a couple times, meetings that were also accredited by CARF, and I don't think we have an exact date. It's May, June. What we do know is they're going to be doing a virtual review for us. We had a virtual review last time and it worked out really well. So I think we'll be fine with that.
How often do you have to go through that?
Every 3 years.
3 years.
Right, you may get less, but we've typically been awarded.
Best
full
case
amounts.
scenario.
Just so you know, I've participated in a panel discussion at the Momentum Center in Holland with some other mental health partners. We viewed the film Coming Up for Air, which is about suicide, and it was a good discussion. We had about 20 people show up, so that was nice. And we have a meeting tomorrow with the Deacons Conference. My brother's house and my sister's house invited us to come and talk to staff. So we'll be doing that tomorrow. And that's all I have unless people have questions or anything I can clarify.
What is the timeline on the block grant for the children's mental health? Is that starting soon?
Yes, it's technically we have the money and the
Oh, okay.
program started with that kickoff.
Great.
So the first year, they've kind of guaranteed it for 3 years, which is nice instead of just a 1 or even a 2-year grant. The 1-year grant, the first year can be used for planning purposes. But we'll give you much greater detail explanation when we do our program updates over the next couple of months. But so our hope with the Children's Mobile Crisis Service is we want to use our community crisis intervention teams. So that's the model where we're working with the Sheriff's Department and Holland Police Department and one of our social workers to do crisis intervention and outreach to the community. What we want to be able to do, and we're talking with the department about it, is we're also hiring some on-call workers for that particular team, the Children's Mobile Crisis Team. So those on-call workers would assist the crisis intervention team when it looked like it was a family or youth issue. So they would be on call and we call them in. The on-call people would also do some of the follow-up because we're expected to follow up with individuals who we've gone out and done those crisis calls with for up to 8 weeks. Okay. And again, I will invite Anne Hardy, who's our program supervisor, who's in charge of that program, to one of our next meetings. And she can give you a much greater detailed update on that.
All right. Any other questions from Lynn? Okay, then general information, comments, meetings attended. Do you have anything? No? Chris, I'm looking across the table at you, and were you introduced at our last meeting?
I believe I was.
You were, okay. I must have totally missed that. Maybe I was late for that meeting, but yeah, welcome to you also as a new board member. And then this is our final opportunity for public comment. Is there anyone who?
Hello, I have public comment. Jewel Wickman.
Okay, and your address, please. We had someone stand up here, so I know you can't see that, but Rosalie, are you okay if we go ahead with your? Okay, thank you so much. Okay.
You are. I already gave you my address. I already gave you my address previously. So I have a few concerns. Is that Lynn Doyle is requesting that the board approve additional money for additional supports coordinators. I think that it's very important for the board to ask what exactly are the current supports coordinators doing according to their job description for the Medicaid manual. From our experience in the field here from parents, they're not doing that much. The staffing shortage, supports coordinators are supposed to assist with the staffing shortage. We've been hearing Lynn Doyle speak about the staffing shortage as her #1 concern over the last 3 years. However, she has never once provided any answers as to what the supports coordinators have been doing or CMH has been doing for the staffing shortage. And also she mentioned that the state is talking about raising the staff wage to $18. However, the last commissioners were under the impression that the state managed the wages at the local level. It's our CMH that manages the wages for the local level. So it's up to Lynn Doyle how much the people can pay their workers, and it's capped. And so it's not a federal concern. CMH is under managed care capitation. So they're given a lump sum, which leads me to my next concern from an organizational budget. I think it's very important to see how many of the unfilled positions that Lynn Doyle keeps opening up is taking from that capitated funding that should be available for the programming for the people. So I'm requesting that a list of the organizational budget be provided so we can see how many jobs are unfilled jobs are taking up the organizational budget and how much are the current staff on the org chart taking from the budget as well. Supports coordinators are allocated $772 an hour. That's more than a neurologist. That's more than a brain surgeon. Okay, so this supports coordinators are the highest revenue probably to CMH. And I think the board needs to really dive deep into exactly what the supports coordinators are doing for the people to allocate $772 an hour out of the budget. And lastly, there should be an acronym sheet. The last commissioners who had been on the board for several years did not know what IDD stood for. And they're supposed to provide oversight for the financial budgets. How can they provide oversight if they don't know that IDD stands for intellectual developmental disabilities? What's very concerning is that the previous commissioners did speak in 2018 and 2019 about how the DAB budget, disabled, age, blind, was their largest revenue, and they felt that the state was not allowing them to allocate enough people towards this revenue so they could serve the most vulnerable population. However,
Well, you have
we haven't
reached
heard
your
anything
time
about that.
limit.
Pardon?
You've reached your 3-minute time limit. Can you wrap this idea up quickly?
I can. I would like a PDF on the CMH website that details what goes under the millage, what programs, how they serve the people, the grants, the waivers, the programs. I have sat through the entire CMH meeting and I probably understand this better than anyone else. And it was clear as mud, honestly. And I have a strong foundation for CMH. So I'd like there to be some more transparency on the website as to what the millage funding is going to, as well as the grants and the waivers that make up the Medicaid funding. Thank you.
Right, thank you. And Rosalie, thank you for.
Rosalie Austin, 457 West 21st Street. Wonder where the LRE bucket report is.
It hasn't been published yet, but we'll get that in the minutes.
And in the minute, I noticed that there's 20K for GBSU scholarships. RCC 13-week training support training program. Not just residential and agency staff that are in a crisis. There's many families without staying. A virtual option for the round table. Now, the curriculum for these certificate programs, what are they learning in 13 weeks? That's over and above. Curriculum CMH. And there should be more parental input training in ESPs and a lot of things that they are lacking to work with the higher needs. That are difficult to serve in day programs. Supports in the community. And the Consumer Advisory Committee to help give this input to patient portal. Maybe there has been card in the mail reminder for an appointment. This was all handwritten, postage, taped on 3 sides. There is a patient portal that for years, I just found out myself. We talked about this at the round table. What are we going to do to improve that so it's actually usable and streamlined efficiencies? Maybe that's contributing to no shows. Just text, email nowadays, reminder. You get it after the summary. That could be in the patient portal. The CARF report. So it's been 3 years when I see and review the CARF report for the next time to make some comments. Organization chart. Council contact people here, like who is the contact person for South Beach? Who is the contact? Last time, this is called the front desk, and they'll get to you when they can, when they have time.
You have reached your 3 minutes, but I don't want to cut you off if you have one. Okay, thank you very much for your input. Anyone else for public comment today?
This is Jewel. I apologize, but I'm asking if I can please make 2 more quick statements. Self-determination is an alternative to supports coordination. So that is an alternative that the board can consider. Also for the CARF accreditations, CMH pays $15,000 for the programs that they are wishing to be accredited in. There are several programs that could be picked that could serve the people. I urge the board to look before you approve the cost of those accreditations. Please look at all the available programs and which ones will best serve the people.
Thank you.
Thank you.
And is there a motion? Our last item on the agenda is just our adjournment. Thank you all for your participation today. Is there a motion to adjourn? Thank you. Is there support for that? All in favor, please say aye.
Aye.
And those opposed, same sign.